As you know, there are three AIDS-defining malignancies, and all of these malignancies are associated with oncogenic viruses, and as I'm sure you've seen in your own clinical practices, these three cancers are becoming less frequent thanks to the development of antiretroviral therapy and the better access to antiretroviral therapy. In fact, some of these malignancies are becoming really rare, actually. You know, how often do you see people with primary cerebral lymphoma these days? We used to see 10 a year, now we see one every 5 years. It's a fantastic advance. And in fact, much of the benefits shown in the START study of early treatment, regardless of CD4 count, were actually reductions in AIDS-defining malignancies, with a significant drop in Kaposi's sarcoma amongst the immediate starters, and a less dramatic but approaching significant reduction in lymphoma in the immediate starters as well. In contrast, there's really been no reduction in the instance and the corrected instance of non-AIDS defining malignancies. And in fact, in our practice, and I'm sure many of your practices, we're seeing more and more people living with HIV who develop non-AIDS defining malignancies. In the DAD study, up to 20% of deaths amongst people living with HIV are now from non-AIDS defining malignancies. And the reason is, of course, because our cohort of patients, people living with HIV, is aging. And that's a great attribute and testament to the enormous benefits of antiretroviral therapy. But with an aging population come the morbidities associated with aging, and the greatest risk factor overall for cancer is getting older. Okay? The older you are, the more likely you are to develop a cancer, any cancer. And as our population living with HIV ages, the risk of developing cancers increases. Not only does the overall risk of non-AIDS defining malignancies increase, but the type of cancers seen varies with the age of the population. So 20 years ago, we saw quite a lot of young men with testicular germ cell tumours and testicular cancers. But actually, the number of the proportion of non-AIDS defining malignancies that are diagnoses of younger adulthood is declining. And now we're seeing more and more common boring cancers like breast cancer and colon cancer and prostate cancer that are associated with a slightly older group of people. The management of cancer in people with HIV is exactly the same as the management of cancer in people who don't have HIV, but there are two things that you need to slightly worry about and concern yourself and make sure that the oncologist knows what they're doing. The first one is the effect of the chemotherapy, or indeed radiotherapy, on CD4 counts and viral loads. And the second issue is the pharmacokinetic interactions between the antiretrovirals and the chemotherapy drugs. In general, combination chemotherapy will drop your CD4 count by about 50%, but it's very variable, and some people it's much more dramatic decline. I recently saw a patient who started with a CD4 count of over 1,000, and during the course of his chemotherapy it dropped to less than 100. It's very unpredictable. In general, it is a reduction in all of the lymphocytes rather than a specific loss of CD4 cells, so the percentage often doesn't vary, it's just the total CD4 count declines. There should be no effect on viral load as long as patients are able to continue to take their antiretrovirals and aren't sicking them up or whatever. But it does mean that you should consider opportunistic infection prophylaxis in all your patients who are going to receive chemotherapy. And that's what we do, and there's some guidelines about that. The next issue is, of course, about pharmacokinetic interactions, particularly around inhibitors of CYP3A4, cobicistat and ritonavir. The effects of this on drugs metabolized through that pathway is really very, very dramatic. So there'll be an almost 5-fold increase in the area under the curve of the chemotherapy agent that is metabolized through this pathway if you're giving simultaneously cobicistat or ritonavir. And almost all of the drugs that cancer doctors use are metabolized through that pathway. Okay? All the old chemotherapy agents were all derived from nature, whether it's the Vinca alkaloids or which were from periwinkle, or the anthracyclines, which was from soil molds, or the topoisomerases, which derived from various trees, and the taxanes from the bark of the yew tree. All these things that we picked up off nature and used to treat cancers are all metabolized through that same pathway. Okay? So you are going to increase the dosage of your chemotherapy agent 5-fold if you give it simultaneously with a booster. But it's not just the traditional chemotherapy drugs that you're kind of familiar with, all those ones that that were derived from nature. It's also all of the new NIBs. Anything that ends in the word nib, cancer nib, is also metabolized through that pathway. All these lotinibs and sorafenibs and sunitinibs, many, many more drugs than you might think. And of course, those nibs are all tablets. They're all oral. So it doesn't really feel like chemotherapy, the patient's just on some oral tablet. But actually, they're not on one oral tablet. They're on 5 oral tablets if you're giving it with the boosters. So that's, and that needs a little bit of education of the oncologist because we're pretty thick-locked. If you pay attention to the effects on your CD4 count and pay attention to the drug interactions, and assuming that the patient is known to be HIV positive when you start their cancer therapy, the treatment outcomes are the same in non-AIDS defining malignancies, regardless of your HIV status. So that nobody should be denied proper cancer treatment because of their HIV status. And you need, the onus, I'm afraid, has been put on a combination of patients and HIV physicians to shout at their oncologists and persuade them to treat the patients properly. Here's just some examples. Here you are. In Hodgkin lymphoma, outcome exactly the same in HIV-positive individuals as it is in HIV-negative individuals. Here, data for anal cancer survival. Again, no influence of HIV status on outcome. And finally, one for testicular cancer, germ cell tumours of the testicle, again showing no difference in outcome between HIV-negative and HIV-positive individuals. Now, for the final part of the talk, I was going to tell you a little bit about some of the new and exciting treatment in cancer that you may be aware of. Over the last sort of 3 or 4 years, an increasing number of immune checkpoint inhibitor drugs are being used in a wide variety of cancers, and these have some quite interesting issues for the treatment of people living with HIV. Okay. The adaptive cellular response to cancer and indeed infections involves 2 major steps. The first one is the antigen priming of T cells, and the second one is the effector phase, during which the primed T cells kill targets, in this case cancer cells. Okay? 2 parts of it. And those 2 parts have important feedback mechanisms. The priming involves the recognition of antigen presented on MHC by the T cell receptor, and the negative feedback loop is through CTLA-4 and B7. And if that pathway is activated, it blocks the priming of the T cell. Okay? So that's the negative feedback loop. And again, in the effector, the killing phase, the negative feedback loop is through PD1 and PDL1. Okay? So that inhibits the killing of the target cell, in this case cancer cells. So both of those, so this is called those 2 feedback loops are called immune synapse, because people can draw it and make it look like a neurological synapse, as far as I can work out. And here you are, the 2 steps: the antigen priming CTLA-4 step, feedback loop, and the effector feedback loop via PD-1 and PD-L1. There are now drugs available to block both of those steps. Okay? So what that effectively does is takes the handbrake off the immune system and encourages the immune system to kill target cells, including cancer cells. That's the theory, and indeed, that's the practice. And it's been shown to be absolutely magnificent in a whole load of cancers that are, in general, relatively refractory to traditional, chemotherapy and radiotherapy. And suddenly you got a whole new group of drugs that work really quite well, surprisingly. And every week, another cancer type is shown to be effectively treated by immune checkpoint inhibitors. So that list is already out of date. They're treating liver cancers with these, on top of that list as well. And the side effects of these immune checkpoint inhibitors, again, are really interesting and to some extent somewhat familiar to you HIV physicians, because it's not that dissimilar to some of the iris effects, which is again taking the handbrake off the immune system. The immune system starts recovering, and you get all sorts of immunological toxicities. In the case of immune checkpoint inhibitors, you can get really quite severe things like quite severe colitis and hepatitis and all those sort of autoimmune phenomena that you're familiar with. And in the case of immune checkpoint inhibitors, they're generally quite easily treated with very high doses of steroids. So what about immune checkpoint inhibitors in people living with HIV? Firstly, do cancers in people living with HIV also express the targets, the PD-L1 in particular? Secondly, what are the effects of immune checkpoint inhibitors on the cancers in people living with HIV? And then what are the effects of the immune checkpoint inhibitors on the HIV itself? Firstly, it doesn't look as though there's any difference in the levels of PD-L1 expression on cancers in HIV positive versus HIV negative individuals. So here, in the case of non-small cell lung cancer, about half of non-small cell lung cancer express the targets regardless of their HIV status. And we started looking at a subgroup of Kaposi sarcoma. I'm sure you come across these patients as well. More and more of my patients with Kaposi sarcoma actually have very well-controlled HIV. They're guys with CD4 counts of 400, completely undetectable viral loads, been on antiretrovirals for some time, and yet have progressive Kaposi sarcoma. And those are kind of quite difficult to treat those guys because you can't manipulate, well, you don't feel that manipulating the antiretrovirals is going to make any difference because actually they've got pretty good numbers at any rate. So we wondered whether what the mechanism of effectively immunological escape of the Kaposi sarcoma in that subgroup of individuals was. And so we stained KS tumour samples derived from those patients and showed that half of those patients, the tumour cells, the spindle cells of Kaposi sarcoma, were actually expressing PD-L1, so blocking the T-cell responses against the Kaposi sarcoma as a method of escaping the immune system. And actually, the ones that were showing lots of blocking had really dense infiltrates of CD8 cells in the tumours. So the T cells were all there trying to kill the Kaposi sarcoma, but the Kaposi sarcoma had put the PD-L1 up and were escaping it in that way. And that's why there's only one study reported, actually, of the use of these class of drugs, the immune checkpoint inhibitors in Kaposi sarcoma. It's a very poor study from America. I say it's very poor, not just because it's from American, though, clearly it is related. But, they mixed up a whole load of patients. Some of them were on antiretrovirals, some of them weren't, it's crap, but... Okay, so what about the effects of these immune checkpoint inhibitors on the HIV itself? It's been known for some time that T cells, CD4 and CD8 cells in people living with HIV express these PD-1 and PD-L1. And indeed, really early ex vivo studies showed that if you block the PD-1 and PD-L1s with mouse antibodies in those days, it increased the anti-HIV gag responses. Okay. So there was a very recent report published in February of this year of one patient in France who was HIV positive, who was treated with one of these immune checkpoint inhibitors for his lung cancer. And during the course of that treatment, the total HIV DNA, the proviral DNA, declined, suggesting that as a side effect of the anti-cancer therapy, the nivolumab was in some way depleting the HIV reservoirs. Certainly that was how it was interpreted. And this is the data. You'll notice that during this process, and I've forgotten which one is the viral load at, I don't know, what's that, a month and a half in, actually showed a blip. So that may actually have primed the immune system even better to result in these declines in the total HIV DNA. Previous studies, case reports, both of nivolumab, that's the CTLA-4 one, the priming blocker, and of nivolumab, that's the effector arm blocker, had shown, although some increases in T-cell specific responses, they'd shown no evidence of an effect on the reservoirs. So previous studies had not shown this. And we have looked at 3 patients treated with nivolumab, looking both at the total HIV DNA and at the integrated proviral DNA using an allo-PCR. We've shown no effect whatsoever in 3 patients over a prolonged period of time. But nonetheless, there's quite a lot of excitement about the possibility that immune checkpoint inhibitors may be used to deplete HIV reservoirs. But as I've shown you earlier on, these are drugs with very appreciable toxicity. So I don't think there's all that much enthusiasm at this stage for treating everybody with well-controlled HIV with nivolumab to try and deplete the reservoirs. But you can see that it's another direction of travel for the cure agenda. And for once, it's something useful for HIV's come out of oncologists rather than oncologists spending all their time refusing to treat people living with HIV. Political comment. Anyway, excuse me. What I hope I've shown you is that the outcomes for people living with HIV who develop a cancer are the same as for HIV-negative people with the same cancer, as long as they are treated in the same way and as long as the HIV is diagnosed. And you must persuade and cajole your oncologists to look after your patients properly. Clearly, that includes attention to testing everybody who's needing treatment for cancer, as well as ensuring that the correct opportunistic infection prophylaxis and attention to pharmacokinetic interactions is paid. Cool. Thank you very much.